And here's a meta-analysis in 2016 of cohort studies of sodium. You could see that consistency across studies, time and again, average sodium or moderate sodium does better than low sodium consistently across studies. So it's not just PURE showing this. PURE sure is the largest study showing this, but it's not the only study. And this is recently in 2016 in JAMA in a paper by Mills. This is the CRIC study, sodium excretion and risk of cardiovascular events in people with chronic kidney disease. Now in this study, they use multiple 24-hour urines. That's the most rigorous way to measure sodium. And you could see, now for the different outcomes, composite CVD, congestive heart failure, MI, and stroke, you see that I also drew with a red horizontal line the current recommendation of 2.3 grams per day. You could see that at high levels above about 4.5 grams per day, there's an increase in the risk for future cardiovascular events in this population. But you can see that the average level in Western populations is 3.5 to 4.5 grams per day. In the US, it's 3.5 grams per day. Based on this data, lowering from 3.5 to lower levels will not reduce cardiovascular events. You could see that clearly here, again using multiple 24-hour urines. And then they also presented their data by quartiles of sodium intake, where lowest level is the reference group. You could see that the second highest level of sodium intake, the one level above the reference group, actually has a lower risk or trends for a lower risk. And so again, it still does not show that low sodium is better than average sodium intake compared to what the population consumes in Western society. So our most recent paper published in the Lancet in 2016, here we looked at sodium excretion versus clinical events in people with and without hypertension. And this is at 133,000 people, data pool across 4 studies. Overall, you see the figure at the top middle, there's a U shape. About 3 to 6 grams per day were associated with lowest risk. Similar to the results in the previous analyses, above 6 grams per day we see an increased risk. Below 3 grams per day we see an increased risk. Now looking at hypertensives and non-hypertensives separately, at the low end we see that low sodium is associated with increased risk regardless of blood pressure. So the potential harmful effect of sodium on events is independent of blood pressure at the low end. At the high end, we see that it's largely driven by blood pressure, since we see an increased risk in hypertensives, but not in normotensives. So there's dual competing mechanisms. At very high levels of sodium, blood pressure becomes important. You get an increase in the risk of events. At the low levels, there's some other mechanism that's playing a role that's possibly increasing risk. We also plotted blood pressure, systolic and diastolic, versus sodium. This is in the same 133,000 people. Red is hypertensives, blue is normotensives. You could see the slope clear. With higher sodium, we see higher blood pressure, consistent with the intervention trial data. So again, the criticism of our method is largely unfounded. You can see there's a clear relationship with blood pressure despite the criticisms of some people.